Good afternoon. I'm very delighted to see many new faces today compared to those yesterday sessions. And those who attended yesterday noticed that I asked a lot of questions, so this time I'm going to ask you the question instead of me ask a question. Metabolic syndrome risk and the consequences different between men and women. Okay. You may think, well, when someone has heart disease and someone has lung disease, how the consequences, risk are different. Okay, that's what I would like to talk with you. And the concept and ideas of this particular topic was conceived and executed by the co-author who are listed here. I'm just a mere presenter and with intense interest in this topic. Metabolic syndrome is quite different from lung disease, kidney disease, and heart disease, and so on, because metabolic syndrome is a group of signs and symptoms that occur together. And they are characterized by particular abnormality and conditions. So how do we measure those metabolic syndrome? Systematically, we use these 5 criteria. We can divide these into 3 categories. One, the weight circumference, which is the indicator of the visceral fat, indicator of the obesity. Second, dyslipidemia, as indicated with the triglyceride and the low HDL. And then the insulin resistance with the elevated blood pressure and the elevated fasting blood glucose. Out of this slide, I do not expect you to remember all of these numbers, but I would like you to pay attention to those factors that 2 variables, elevated weight, the excessive weight circumferences, and then low HDL, have 2 different the reference point for men and women. And the weight circumference, certainly men is allowed to have a little bit broader waistline, and HDL, women is allowed to have or expected to have a little bit higher reference point. And then the other 3 are triglyceride and blood pressure and a fasting blood glucose. And then these 3 are quite related. So in the US, many practitioners and physicians consider diabetes as a heart disease. How could you call diabetes a heart disease? Because the risk of the heart disease increases dramatically. Then my question is, why is heart disease so important? The reason is, even though many of us worry and fear about the cancer and other illnesses, still the number 1 killer around the world is cardiovascular disease. And then for a long time, cardiovascular disease was considered a man's disease. However, women's death by the cardiovascular disease is equally high and increasing. So based on this information, we see across the globe how is the prevalence of metabolic syndrome differ. And strangely, and anticipated, the France still presented some of the paradox here. Has the lowest metabolic syndrome prevalence, and then it ranges widely. In the case of Finland, there's no data for female, okay, male with the blue and a female with the orange. And Australia and Ireland and so on goes up. And the US with a non-Hispanic white, somewhere about the 21 and 26, but Native Americans rate is really high. Almost 90% of the Native Americans, okay, American Indians, the prevalence of obesity, about close to 90%, and then about close to 70 and 80% of the American Indians have a diabetic. And some people say, well, when you look at their diet, you should be able to explain. It's a lot more complex than that. Some people claim it's a genetics, some people diet, and there's a lot more that explains under this. So in this case, Korea data is not shown. However, we want to just simply use Korea as a case study. There's a lot more to do. So somewhere Korea data comes between Turkey, Iran, and then India. In the case of the India, many of us already know that Hinduism is very prevalent, and they tend to have a vegetarian diet. And how could they have so high prevalence of the metabolic syndrome? And actually, the cardiovascular disease-related death rate, mortality in India is about 4 to 7 times higher than that of the America, okay, average. So in this case, a diet is not the explaining factor for metabolic syndrome. So prevalence of metabolic syndrome in Korean adults in 1998 on the left one and the right 2007, men as indicated in blue and orange for women. Interestingly, and in 1998, and the women's metabolic syndrome prevalence tailed the men's up until around 40. And all of a sudden, whatever the turning point is, somewhere about the 50s, women outnumber and outproportion. And in 2007 data, and the women trailed men's prevalence and are starting right in 50. And they just outnumber men's prevalence. So in this case, when someone take a look at this data and say, oh, metabolic syndrome prevalence goes up with age, okay, we're all heading for the same tomb, so it makes sense. However, that is not relevant, that is not acceptable. As you look at the men's data, it does not continue to increase with the age, and in both the data sets. So what's happening here, right around the 50s, in both the data set, is kind of an interesting mystery that we wanted to investigate. Okay, so among the Koreans, about 31 and 32%, quite a high rate of metabolic syndrome. So why metabolic syndrome risk differ by sex was our question. The data sets we used was Korean National Health and Nutrition Examination survey data that has about 20,000 adult and about 45% men and 55% women who had no pre-diagnosed diabetes, hypertension, and dyslipidemia. If you remember those 5 categories, if someone already have these kind of illnesses, they would automatically fall into a metabolic syndrome. So the definition and a diagnosis of metabolic definition, classification, diagnosis of metabolic syndrome is based on those 5 indicators that I showed you earlier. So we looked at each of these variables. What I would like to get your attention here in this point is each of these 5 variables, metabolic syndrome, the total, okay, presence and absence, and a blue men and orange women, and just follow the green. And just green bar, then what seemed to be the most problem in Korean adults? Those are 2, elevated or excessive waist circumferences and low HDL overall in population. In those particular 2 indicators, the prevalence of the excessive or excessive waist circumferences are much higher in women, and the low HDL is much higher. With other 3 indicators, the woman trails men's rate. So somehow these 2 are the indicators that has separate the men and women criteria. So by looking at, without separating men and women data, by looking at metabolic syndrome by men and women leaves a lot of blind sight in the science for us to explain. So we further on and are looking at combinations of metabolic syndrome. And by definition, when an individual has abnormal values or 3 or more, they are just simply classified metabolic syndrome. But we need to look at it further. And here's the men and women. And the blue, darkest 2 blues are the highest prevalence. And then darkest orange are the highest prevalences seen in women. In the case of the men, elevated or excessive waist circumferences, elevated triglyceride, and a low HDL is the number 1 combinations that explains being classified metabolic syndrome, and followed by the elevated triglyceride, low HDL, and elevated blood pressure. So in this regards, these 2 are kind of common with elevated triglyceride, low HDL-C. Yesterday, when Dr. Song Yunzu made her presentation, someone said, well, you're talking about eating carbohydrate, and why are you talking about the blood? Okay, metabolically, those of you who are in medicine, when we eat all those rice during the lunchtime and lots of carbohydrates and sweets, when we consume those, they are converted into, certainly with the sugar, but into the fat. Okay, so here's the different patterns of the combination of this too. Then, what are the risk factors of metabolic syndrome? They are gender-related behaviors such as alcohol. These are the modified variables: alcohol, physical inactivity, tobacco, and unhealthy diet. As a nutritionist, and certainly we paid attention to the diet, but with the current research method, there's a way in the nutrition epidemiology, there's a way to control the alcohol, physical activity, and tobacco statistically, okay? And we cannot make them stop drinking and stop doing the physical activity, but at least a statistical adjust to sort out the effect of the healthy diet alone. And these kind of studies have been already published. So basis diagnostic criteria, low HDL and excessive weight circumference issue. Very interesting thing here is the reference point difference between men and women. And these are set in a Western country, in the US, and these men and women, and these are what we use, okay, across the world. And interestingly, what is end point of setting this HDL is based on insulin resistance or hyperinsulinemia, and insulin resistance men in the US, hypertension men and women in Sweden and Finland. So obviously, we've been lacking with the data to set up the reference point in the Asian population, particularly Korean. And 2015, one group of the scientists came up with the different values for men below 43 and below 48 women, men and women respectively. Elevated waist or excessive weight circumferences. Again, we've been using one standard method, but there have been some of the questions. The end point used in this setting, the reference point, is cardiovascular disease risk factor. So once in a while, we need to check what is the basis of setting these references when the reference point is not relevant to particular gender and gender, sex, and a population. How applicable is it in public health or in a person? So different effective metabolic syndrome in chronic diseases, at least cardiovascular disease morbidity, mortality was the beginning point of setting this reference point initially. And according to this, metabolic syndrome, even though we use exactly the same, in this Western population, and women's, the cardiovascular disease risk seems to be a lot stronger, have stronger relationships than men does with the cardiovascular disease. So conclusion and implications is just the bottom line is this. Whenever we get the research done, and this is one argument I have with my doctoral student, and when we get the research done, we actually have more questions. So here are the questions. And reestablishing sex-specific diagnosis, a diagnostic criteria of metabolic syndrome, and different populations, and different settings. And we need much more information before we go on. So with this, and I thank you.